Depression is one of the commonest disabilities worldwide, affecting 1 in 20 people. But what does it actually mean to have depression? There is no magic test to diagnose depression, which makes it a clinical diagnosis. This means the diagnosis is made by a doctor based on signs and symptoms that a patient presents with. To help understand depression, it's useful to think of our mood as always being somewhere along a spectrum, with mania being at the top and depression at the bottom. Mood can be defined as someone's emotional state at a particular point in time. It's normal for our mood to fluctuate, but it doesn't often reach the extreme ends of the spectrum. Individuals who live with depression will experience their mood reaching the extreme low end. These episodes can be severe and last for prolonged periods of time. When someone experiences moods at both ends of the spectrum, this is known as bipolar. I've got a separate video on this if you want to learn more. The symptoms used to diagnose depression are defined by the ICD-10 guidelines as being core symptoms and associated symptoms. Core symptoms include low mood, anhedonia, which means it's difficult to experience pleasure from things, and low energy. Associated symptoms of depression include sleep disturbance, typically presenting as early morning waking. Appetite changes can be either eating excessively or not having the desire to eat, which can result in weight changes. Loss of libido and suicidality are also features. The severity of depression can be identified based on the number of symptoms someone is experiencing. Mild depression is often categorized as having 2 core symptoms and 2 associated symptoms. Moderate as having 2 core symptoms and 3 associated symptoms. And severe is having all 3 core symptoms and 4 or more associated symptoms. When someone's experiencing these, it's known clinically as a depressive episode, and multiple episodes are referred to as having recurrent depressive episodes. It's also important to know, as with many other psychiatric illnesses, depression in its extreme form can result in symptoms of psychosis, such as hallucinations, where someone may experience noises, visions, or smells of things that aren't present. In depression, these are often unpleasant sensations, like hearing accusatory voices or smelling rotten food. Delusions are strong, unshakable beliefs of things that aren't actually true. These can include believing you are responsible for negative world events, or believing you've performed some sort of misdeed. Thought disorder can be another feature of psychosis, where someone's thoughts may feel as though they are being manipulated. Before we move on, I want to highlight the importance of performing a risk assessment for patients with mental health difficulties. It's essential to assess risk of any patient presenting with psychiatric illness. Patients can be a risk to themselves, pose a risk to others, and be vulnerable of risk from others. So, taking a psychiatric history should therefore always include questions around these 3 headings. So, what causes depression? Like with most psychiatric conditions, the exact cause is unknown, but there are multiple factors that are known to play a part. Firstly, research supports the theory that people can have a genetic predisposition to developing it. Of particular note is a serotonin transporter gene, whose role is to allow reuptake of serotonin from synapses between neurons in the brain. Mutations to this gene that increase its activity are associated with depression. In fact, the medications we use to treat depression target this. Selective serotonin reuptake inhibitors, like sertraline or citalopram, act by blocking the effect of these serotonin transporter proteins, and result in increased concentration of serotonin within synapses. Another factor contributing to depression is biological vulnerability, of which there are many examples. Structural or functional problems with the brain can predispose to depression. For example, changes to the amount of blood flow to particular areas in the brain. Reduced quality or quantity of sleep are also scientifically proven to be a biological vulnerability for depression. Personality is also an important factor. Certain temperaments, for example neuroticism, are thought to contribute. Experiencing adverse life events or having difficult social circumstances are also important factors. The development of depression is therefore multifactorial, with multiple factors interacting with one another in a complex web. Management of depression, like any other psychiatric illness, should focus on biological, psychological, and social therapies. Biological management focuses on medications. Antidepressants are commonly used, of which there are multiple classes to choose from. Unless contraindicated, SSRIs are often used as first-line treatment. As previously mentioned, these will increase the concentration of serotonin in the synapses between neurons. SNRIs and tricyclic antidepressants are two other classes, but are less commonly used than SSRIs. Antidepressants will typically take around 4 weeks of use to see beneficial effects. It's also important for patients to continue taking their antidepressants for around 1 year after their depression has resolved. This will reduce the risk of relapse. Antipsychotic medications can also have a role in managing depression that have features of psychosis. Electroconvulsive therapy, or ECT, is rarely used to treat depression. It isn't recommended by NICE due to lack of evidence, but it is occasionally used to treat depression that's life-threatening and treatment-resistant. Psychological therapies involves talking with a clinical psychologist or other mental health professional. For depression, this can be using CBT, where the focus is on controlling the mind and changing damaging thought processes. Counselling can also be an effective talking therapy. Social support can be varied, but may include supporting someone in engaging with social activities and exercise, or working with a voluntary service. Thanks for watching, and feel free to watch my other videos on psychiatry.